Hello, my name is Lieutenant Commander Carr, and I'm a General Surgeon at the Bremerton Naval Hospital. My goal today is to put together a suturing course, the idea for which came about after talking to two people who work in the Bremerton OR. They were taking online first assistant courses which required them to learn multiple techniques, including multiple suture techniques. My specific purpose is to create something more permanent so the individual learner, through using this course and through their own motivation and repetition, can learn these techniques well. With that, I'd like to dedicate it to the corpsmen in the Navy. I've been active duty now for approximately 3 years, and it's clear to me that the corpsmen are pretty much the engine of Navy medicine, and nothing that we get done could get done without them. A little history of the Corps as I understand it. The Corps was officially started in 1898, but unofficially existed much longer before that. The corpsmen are critical. They are the front line medical support. They are the first responders in all battles. They've been known to do 14 or more appendectomies on submarines alone. They hold more than 20 medals of honor. They hold more than 900 silver stars, and they hold more than 1,500 bronze stars to their corps. And as part of that, I'd like to read the Hospital Corpsman Pledge, because it pretty much exemplifies the core values of the Navy: honor, courage, and commitment. This is the pledge. I solemnly pledge myself before God and these witnesses to practice faithfully all of my duties as a member of the Hospital Corps. I hold the care of the sick and injured to be a privilege and a sacred trust, and will assist the medical officer with loyalty and honesty. I will not knowingly permit harm to come to any patient. I will not partake of nor administer any unauthorized medication. I will hold all personal matters pertaining to the private lives of patients in strict confidence. I dedicate my heart, mind, and strength to the work before me. I shall do all within my power to show in myself an example of all that is honorable and good throughout my naval career. And with that, let's get started. As I get started, I'd like to review my primary sources for the course. First, I read the beginning of the Principles of Dermatology book in order to review the anatomy of skin. Number 2, I reviewed part of this wound closure manual, especially for the anatomy of a needle, put out by Ethicon. Number 3, my favorite surgical techniques book, put out by Gary Wind and Norman Rich, is this. I met Gary Wind at approximately 1995 at USUS, and ever since then I've had this book, and it's phenomenal. The last book that I reviewed is actually one I bought about 6 weeks ago. It's a book on all kinds of knots, dozens and dozens of knots, and I put into context what we do in the OR. And in the OR we essentially tie a square knot, granny knots, and surgeon knots. But that is a small part of the world of knots. And I would say this book for military people can be of use, especially on deployments, learning how to tie 550 cords in all kinds of ways for all kinds of purposes. And finally, my training is paramount to this course, to my knowledge and my techniques. I went to Vanderbilt University, and I was a small part of a much greater whole, and these are all the people who helped train me. And finally, got to thank my family, especially my wife, my primary support, and she's the one taping right now. So let's get started. When doing any surgical procedure, no matter how minor or major, it's important to always consider the underlying surgical principles. These principles include the following: 1, anesthesia; 2, asepsis; 3, exposure; 4, hemostasis; 5, surgical technique; and 6, safety. For anesthesia, for minor procedures, we generally only need to use a local anesthetic to provide pain control. In addition to providing analgesia, the anesthesiologist and anesthetist provide amnesia so the patient forgets their procedure, and they also control the patient's sympathetic responses when they're under general anesthesia. Essentially, they control their vital signs, in addition to providing hydration. For asepsis, We prep and drape the patient. We prevent breaks in the sterile field. Sometimes we provide intravenous antibiotics. And it's even important when we shave the patient's hair. We do not permit patients to shave their hair a day or two before the procedure, since this is associated with higher wound infection rates than when we just shave them immediately before a procedure. For the third surgical principle, exposure, lighting is absolutely critical. Both the use of quality overhead lights and even sometimes the use of a headlight. The position of the table is important, the position of the patient on the table is important, as well as the use of retractors and even the size of the incision. For the fourth principle, hemostasis, all mechanical means that we use to obtain hemostasis essentially puts direct pressure on the point of bleeding. We have other means of providing hemostasis using products such as Avitine, Surgicel, Gel Foam, Thrombin, and even some of the newer, fancier products like QuikClot and HemeCon dressings. For surgical technique, it is important that the surgeon handle all tissues gently and that we keep all tissues moist. And finally, for safety, there are numerous safety measures that we take when doing a procedure. Some of the ones I'd like to highlight are the following. The first, using a safe zone for sharps, so we prevent inadvertent injuries to the patient, to the operator, and to the personnel around the table. Number two, the use of the Bovie housing in order to prevent inadvertent burns to the patient, the surgeon, and to the operating personnel. And finally, something as simple as securing the patient to the table to prevent any slipping or sliding when we use extremes of position with the table. And with that, let's go ahead and get started with the anatomy of the skin. Let's review the anatomy of the skin, and let's keep it simple. The skin essentially has three layers. The topmost layer is the epidermis. It provides a barrier around the body. The epidermis is almost paper thin. Underlying the epidermis is the dermis. It varies in thickness according to the region of the body, and the thickness is anywhere from 1 to 4 millimeters. Underlying the dermis is the subcutaneous fat. Underlying the subcutaneous fat is fascia and muscle. The dermis is the strength layer, and it's the layer that holds sutures well because it has a large degree of connective tissue. It also harbors blood vessels, and it also harbors skin appendages, including hair follicles, sebaceous glands, and sweat glands. This here is some pork skin. Farmer George's butcher shop provided 10 pounds to me for this course. You can see at the edge, the white is where the dermis is, with also subcutaneous fat under it. The very top part is epidermis. And throughout this course, we will be using this pork skin. Let's review suture materials. In order to select the suture, one must determine what kind of wound they're closing and how they're going to close it. When you bury stitches within tissue, you usually use absorbable suture. When you do external stitches, one usually uses non-absorbable sutures. There are several types of each, and I will show a few here. For absorbable sutures, the suture that retains its tensile strength the least amount of time is plain gut. Plain gut is a natural substance, and it is manufactured from the intestine of animals, either from the submucosal layer of intestine or from the serosal layer of intestine. It retains its tensile strength when it's used to close a wound for approximately 7 to 10 days. Chromic gut is similar to plain gut, but it's treated with chromium salts, permitting it to be absorbed more slowly and helping it to retain its tensile strength for wound closure over a period of 10 to 14 days. Vicryl suture and monacryl are not natural substances, but they are absorbable. They both retain tensile strength on the order of weeks to months, providing more strength to a wound over a longer period of time. There are several types of non-absorbable sutures as well, including nylon suture, which is this, polyester suture, which is this, and other sutures such as Prolene. These sutures are generally used when closing wounds as an external stitch that is later removed. Now let's review the anatomy of a needle. A needle has a point, it has a body, and it has an eye or a swage to which the suture attaches. Of importance to the anatomy of a needle is its curvature. There are multiple different curvatures to multiple different needles. There are straight needles, and then there are needles with multiple different kinds of curves. Anywhere from a quarter circle, to a 3/8 circle, to a half circle, or a 5/8 circle, each having their own uses. One of the most common that we use for skin closure is the 3/8 circle needle, which this nylon suture is. All needles have codes attached to them. One of the sutures and needles that I will be using most commonly during this course is a 3/0 nylon suture on a PS2 needle. The 3/0 refers to the size of the suture itself. 4/0 is smaller than 3/0. 5, 6, 7/0 gets smaller. 2/0 and 0 are larger than 3/0. And the larger sutures are 0, number 1, number 2. All needles have a code. PS stands for plastic surgery. Another common code is SH, which stands for small half circle needle. Other codes include RB, which stands for renal bypass, FS, which stands for foreskin, CV, cardiovascular, CT, circle taper, CTX, circle taper extra large, and BV, blood vessel. There are multiple other codes, as you can see here, each having their own uses and purposes. The PS2 needle is a reverse cutting needle. The importance of that feature is that the cutting part, or the edge of the needle, is on the outside curve of the needle, not on the inside. The inside is flat. This is important when we pass the needle through the dermal layer. If you use a reverse cutting needle, the needle will not cut back toward you through the dermis, and it's less likely to cut out the suture itself. When the edge is on the inside, as you pass through the dermis layer, it's more possible for the needle to actually cut through the dermis and through a suture. When suturing skin, just a few instruments are needed. First is a needle holder, of which there are multiple varieties. When suturing skin, I prefer to use a shorter needle holder, which minimizes any intention tremor from revealing itself at the end of the instrument. It also allows me to control a needle a bit better. Of course, there are longer needle holders as well, and ones that are heavier duty for larger needles. When holding any instrument with rings, one can put their thumb in the ring closest to them and their fourth finger in the ring distal from them. Then the shaft of the instrument is braced off the middle or third finger and the index finger. That gives maximum control over the instrument. By taking the thumb out of its hole, it makes the instrument more in line with the arm. Essentially, the instrument becomes an extension of the arm, and pronation and supination become easier. Some surgeons will suture with both their thumb and their fourth finger out of the rings. This is called a palming technique. This is much more advanced and requires a lot of practice. My preference is to keep my fourth finger in its ring, and then usually take my thumb out of its ring in order to make the instrument a natural extension of my arm. The second instrument that you need is some form of pickup to pick up the skin edges. What we commonly use is an Atzin forceps. The Atzin pickup has one tooth at the end of either side. This minimizes trauma while picking up a skin edge. Another form of Atzin is the Atzin-Brown forceps. The Atzin-Brown forceps, instead of having just one tooth, has multiple teeth in longitudinal rows. Difficult to see, but they're there. And what those multiple teeth do in longitudinal rows, as one picks up the skin edge, is it distributes the force over a wider area and even minimizes tissue trauma further. The Atzin-Brown also permits the operator to pick up a needle more easily with the instrument if he or she prefers. Finally, one needs scissors to cut suture. Scissors are held the same way that you can hold a needle holder. Thumb in the first ring that's close to you, fourth finger in the distal ring, the index finger and middle finger brace off the shaft. When you go to cut suture, if you have an intention tremor and you want to control it, you can brace your forearm over your other forearm, and that will maximize your control in cutting exactly where you want to cut. I'm going to cut the pork skin now and start the suturing techniques. Before I cut, I want to briefly review different scalpels. There are many more different scalpel blades in this, but these are pretty common ones. Number 10 blade is a general purpose blade. It's rather large, but can be used for large incisions as well. Number 11 blade has a point, this is number 11, at the end of it. And this is used mostly for I&D'ing things like abscess cavities. This number 12 blade is not used that often, but it's one that has a curve to it and is used to open sinus tracts. And finally, number 15 blade is sort of a smaller version of a 10 blade. It can be used for smaller incisions. When grasping a scalpel, and use a larger blade for a longer incision, you essentially bounce it off the middle finger and then grasp it. That gets you somewhere near the middle of the blade. With experience, one can just pick it up and it'll be well balanced. For a scalpel like this, using a 15 blade, it's usually for smaller incisions. You can hold it like a pencil. And with gentle pressure, you can make your incision. I have to open up the pork skin a little bit because it's dead. Next, one obtains a needle holder and suture. In this case, we're going to use 3/0 nylon on a PS2 reverse cutting needle.
When grabbing a suture or a needle, you never want to be in the first half of the curve of the needle. You'd like to be at the halfway point, or probably even preferably at about the 2/3 to 3/4 point. Never angle a needle toward the shaft. It's very hard to sew like that. It's very rare that you angle a needle away from you either. In general, you keep the instrument perpendicularly on the curve, and you can angle the needle slightly away from the shaft. That gives good control. The next thing to think about when you close an incision is you'd like to bring the point of the needle perpendicularly to the tissue. So if you see where I've made this X with marking pen, I do not want to enter the skin at an acute angle. I'd like to enter it at a right angle to the skin. And sometimes when I'm doing simple sutures, I may even want to go slightly beyond a right angle. That would help me actually evert the skin edges as I close the wound. In order to get that angle, I both manipulate the skin edge, and I also have my fourth finger out of the ring, allowing me to pronate my hand as much as I can to get the needle where I want it. So now let's start with a simple suture. With suturing, you want to minimize the trauma that you provide the skin. So you like to pick up the skin once with your Atson, take your needle, and at right angles, go through the epidermis into the dermis. You can come out at the bottom of the dermis or just underneath the dermis. And that decision really depends on how thick the dermis is. Pick up your other side, go in at right angles, come out at right angles. Pull the needle through by grabbing it with your needle holder, and you always follow the curve of the needle when picking it up. And we'll review that again with the next stitch. When tying, you use an instrument tie in this case. And you do an instrument tie, I always pretend there's a hole between the working strand, where the needle is, and the non-working strand on the other side. That's an imaginary hole there that I can complete out here. If you always keep your instrument in the hole, then you will tie square knots. Also look at where my strands end up. They end up opposite from where they begun. Let's do it again. I'm tying a square knot. Strand is here. It's going to end up equal and opposite, 180 degrees. Stay in your hole. Do not go outside your hole. That will not give you a square knot. Stay in your hole. So this is a simple stitch, which is the most common one that you will use to close wounds in general. Stay in your hole. Now when I suture, and I'm using my needle holder, I have my thumb in the proximal ring, my fourth finger in the distal ring. I stay in my hole. Common mistakes are when people go too close to the knot to tie their next knot, and then they can't pull their strand through the hole. Your imaginary hole is much bigger, so give yourself length on the suture and just stay in that imaginary hole. And you're moving both your instrument in your right hand and you're moving your left hand, or vice versa for left-handers. Stay in your hole, move both the instrument in a rotation movement and your other hand in rotation movement, and then bring both the hand and the instrument down to your non-working strand. Stay in your hole, wrap the working strand around your instrument using both the instrument and your other hand. Move both hands and the instrument down to your non-working strand, and then pull your non-working strand through the loop, bringing it 180 degrees from where it was laying. It's going to end up over there now. Stay in your hole, wrap, bring through the hole, 180, and the knot lays down flat. So now let's cut this. Cutting technique: fourth finger and distal ring, thumb and proximal ring, index finger and third and middle finger bracing off the shaft. Go in. You control where you cut. Scissors are made for right-handers. That's because the thumb naturally pushes down on its ring, while the fourth finger naturally pulls up on its ring, thereby bringing the ends of each side toward each other. This end is pulled up, so the end goes down. This ring is pushed down by the thumb, so its end comes up, causing the two blades to grate against one another. When using the left hand, it's very hard to cut because the natural motion brings these two blades apart from one another. That's why many people cut underhanded when they use the left hand, because then the natural motion for this ring and for this ring is to push the ends of the blades into one another and thereby make the cutting with the left hand easier. Next suture, I want to place the needle in at a right angle, facilitated by having my fourth finger out of the ring, allowing me to pronate as much as I can. And also it's facilitated by lifting the skin edge so I can go in at a right angle more easily. You follow the curve of the needle through the tissue. You push it through further, and I have two options. I can reload in the tissue, or I can pick the needle up and reload outside the tissue. Either way, you want to pick the needle up in a pronated fashion, so it's easier to supinate and go at the curve of the needle as you pull it through. Readjust the instrument in your hand. And then come through the other side. Stay at right angles to the tissue. I'm holding the skin. I picked it up once, skin edge. I'm holding it. I'm not changing my grip. The more you pick up the skin, the more you traumatize it. Now you pick up the suture where the needle is. Let the needle go. Both instruments are still in my hands. I'm not putting anything down. I have my imaginary hole here, and I'm going to stay in it. But I give myself room to wrap the suture around the instrument. Now for a surgeon's knot, you wrap the suture twice around the shaft of the instrument. Now watch how both hands are moving to facilitate that wrap. Surgeon's knot, I'm going around twice. Move both my hands and the instrument to the non-working strand and pull that non-working strand through the loop and bring it down flat. I do the same thing. You can notice it's easier to wrap where you're holding the working strand. It's much harder to wrap down here. There's so much strand it falls off easily. Wrap close to where you're holding it, and then move both hands in the instrument down to the non-working strand and bring it through, and you end up 180 degrees from where it was laying. That's a square knot. The purpose of the surgeon's knot is that the initial two wraps around the instrument creates more friction in the suture and prevents it from slipping for that very first knot. Okay, let's cut again. Once again, scissors are a right-handed instrument primarily. If you cut with the left hand, generally I hold it upside down, so the natural motion is to push these two blades into each other, and then it cuts more easily. Let's do that one more time. I would say repetition for procedural things is the most important thing. The knowledge initially is declarative knowledge, it's just information, and the more repetition you do, it becomes procedural and converts it into muscle memory. So right angle, follow the curve of the needle, go through the dermis if it's really thick, or just under the dermis if it's really thin dermis. Pick the needle up, following the curve of the needle. Pick the other side up with your instrument one time. Pronate the hand. Pick up the needle in its natural curve and supinate to come out. Let go of the needle. Grab the working strand where the needle is with your left hand, or right if you're a left-hander. Surgeon's knot, 2 wraps, creates more friction in that wrap. So when you place the first one down, it's less likely to slip. In general, when you place these knots, you like them all to be on one side. And if you place your knots at right angles, or maybe even a little bit beyond the right angle, it's more likely for the suture to bunch the dermis up underneath it just a little bit to evert the skin edges and not invert them. You do not want the skin edges inverted. So those are simple stitches. That's one of the most common that you'll do for clean wounds when you do external stitches like this. The next skill that I'm going to show is a figure of 8 stitch. This is on a list of techniques that this online first assistant course required folks to know. That's why I'm showing it. A figure of 8 stitch is almost never done on the skin. It's usually done in a deeper layer. Sometimes we close small laparoscopic incisions, the deep fascial layer, with a figure of 8 stitch. This is a pretty simple stitch. Once again, take a bite of tissue. Follow the curve of the needle. Take another bite. This is a blunt needle, so it's hard to get through skin. Bring it through. And then you take another bite for each side before you tie. Make sure you don't go behind your stitch. And like I said, this is not a skin stitch, but I want to show it since it's part of this technique list. You can see how your 8's oriented. And then you can tie your stitch down. And we'll do some knot tying later. This stitch is the horizontal mattress stitch. It's another external skin closing stitch. Go into the skin at a right angle. I'm coming out just underneath the dermis. That's actually in a fatty layer there. Pick my needle up. Adjust the instrument in my hand. I roll it in my hand to get it back to where it was. Pass it again, just underneath the dermis in this case, through the epidermis, release the instrument. I've grabbed the skin once with this instrument with my Atsin. I'm not letting it go and picking it up multiple times in that one stitch because that just traumatizes the skin. Bring needle through, grab your working strand. In this horizontal mattress, you reload the needle and it has a backhand component to it. Bring it through the skin at a right angle. You pass it back toward the initial side, where the non-working strand is. And then you tie these together. I'll just do a simple stitch here, simple tie. For nylons, or most non-absorbables, I generally place 6 or 7 ties in them. I'm staying in my hole. And you notice me crossing my hands a little bit to try and keep this square. Because this strand starting over here should end up over here. So the suture goes down flat. We'll do that one again. So I go in the side that's far away from me, which is a key point when suturing. You always want to suture in a way that you're suturing toward yourself. It's very hard to suture away from yourself, especially long incisions. Coming out just under the dermis there, that's actually a fatty layer. It's dead tissue, so there's no blood in it. Always follow the curve of the needle. I'm not supinating like this to pick it up. It's too awkward. I'm pronating my hand to pick it up, to follow the curve. Now I got to do a backhand. I could just pick the needle up and reverse it. That is very acceptable. Or you can use the tissue to help move the needle. And your instrument. And then go backhand through the tissue. The horizontal mattress always has one component that's a backhand. Horizontal mattress helps evert the skin edges a bit and covers a little more ground. One more time. Go in tissue at right angle. Pick up the skin edge once. Follow the curve of the needle. Pronate to pick up the needle. Roll the instrument in your hand to reset it. Pass it through the other side. Now you have to go to a backhand, so you can either use your hands or you can use the tissue and your instrument. The next stitch is a running horizontal. The one that we just did was an interrupted horizontal mattress stitch. This is a running horizontal mattress stitch. To do this, I throw a simple one, I tie a knot, and then I run it in a horizontal mattress fashion. Tying, stay in your hole. That's your imaginary hole. Stay in that hole. I wrap close to my hand up here, to my hole here. We'll cut this end a bit shorter. Now I've actually never used a horizontal mattress, but I'm showing this as one of the techniques that first assistants are expected to know. It's a very viable suture. It would close a wound quite well. So I backhand it as I would the interrupted horizontal mattress. Now I got a forehand to come back around. This time I'm going to adjust the needle with my hand. When you pick a needle up, I always pick it up by the swage end. Then it's easy to rotate. Don't try and pick it up near the point because you'll injure yourself, or near the middle because you have nothing to grab. By the swage and rotate it. Come back toward yourself. Come in at right angles to the skin. Come through the skin at a right angle. Once again, pick up the needle, pick up the swage to rotate itself. I've got a backhand it now, so I'm going to load it for a backhand. About 1/2 to 2/3 distance back. Come in at a right angle. Needle's a bit small, so I'm going to take it in 2 bites. This time I need a forehand. And then at some point you have to tie the strands together. So what you would do is you would leave your needle end on one and leave the loop from your prior horizontal mattress free, and then tie them together. These two essentially become one functional unit. And you tie those together, either with a hand tie or an instrument tie. Now in living tissue, it's much more pliable and the skin edges come together very well. My goal for you is to get the techniques down with this CD. Next is the vertical mattress stitch. It's an everting stitch. Essentially, you take full thickness through the dermis, which this is, on both sides. And instead of tying it at this point as you would for a simple stitch, you have to do a backhand stitch. And this time you go through the epidermis and come out in the superficial dermis. A real small bite. And that bite allows you to evert the skin edges in a pretty exacting way. I would say the most common stitches you'll see for skin closure are a simple stitch, a vertical mattress interrupted stitch, and then of course you have the buried subcuticular stitch. One more time for that. This is an interrupted vertical mattress stitch. Pick up skin edge one time, right angle the needle through the skin, follow the curve of the needle. Pick up the other side of skin, follow the curve of the needle. You have a backhanded component. So the first throw is full thickness, far, far, and then near, near, much smaller bite, closer to skin edge. This everts the skin edge. Very common stitch when you use non-absorbable stitches like nylon to close skin. So in general, it's only 4 knots there, but I put about 6 when I'm actually doing it for real in a person, 6 or 7 in nylons. So that's very common. Now, I'm also going to show a stitch that I haven't done before, but it's a running vertical mattress. So you start out the same way you would do an interrupted vertical mattress, far, far. Backhand to do the near, near. Small bite through the epidermis and the superficial dermis. Follow the curve of the needle. Small bite on the other side. That's the near, near. Have to tie that down. Only cut one side because you're going to run it this time. And then you keep on doing far, far, near, near. Far means far from the skin edge, relatively speaking. So far on that side, far on this side. And I got to do a backhanded, near, near. And it's a way of running your suture line and not cutting in between each suture in an interrupted fashion, but yet still everting the skin edges in a more exacting way than just a simple stitch does. So far, far, near, near, and keep on repeating that. Far, far. Near, near. You can see how the orientation of the final stitch will be. And then when you get to the end of your wound, you'll have to sew the suture to itself for the final knot. When you get to the end of the wound, you'll sew it to itself for the final knot. Another common stitch is the simple running stitch. Just like the very first stitch that we did. You pass the needle through either side of the incision. Use your proper techniques. Come through the tissue at right angles. Hold the skin edge once before releasing it. Don't keep on re-grabbing it. And you tie a knot. In this case, I'm going to do a surgeon's knot. That's 2 loops around the shaft of the instrument. Pull my non-working strand through 180 from where it was started. Bring the knot down flat. One common mistake on any kind of knot tying is not keeping equal tension on both strands. If you don't keep equal tension on both strands, then you do not bring your knot down flat. And you need to keep equal tension on both strands all the way down to the prior knot. If you don't, then at any point you can convert it into a half hitch. And half hitches slip. Square knots don't. Now to continue the simple running stitch, you keep on throwing your needle through the tissue over and over without cutting it as you would in an interrupted stitch. Another skill is doing a simple running locking stitch. And that is done by passing your needle through the prior loop. So when you pass it through the second side here, instead of picking it outside this loop, you pick it up inside that loop, which is an important role of a first assistant. A first assistant always makes sure the surgeon picks up his needle through the prior loop. During a locking stitch, the first assistant would have this loop already over, so the surgeon picks it up through the loop. At the end, when you're finished, you need to sew the strand with the needle to the prior loop, which functions as one strand. Sew it to itself to create the final knot. This is the simple running part of that stitch, and this is the simple running locking part of that stitch. A locking stitch is considered more hemostatic. It's rarely, if ever, done for skin closures. However, we do use it commonly on the first layer of a hand-sewn bowel anastomosis. This ensures more hemostasis, so when we close the anastomosis, there's less chance to have an anastomotic bleed causing a GI bleed. Okay. The next suture is a buried knot technique. Ideally, you use absorbable suture, either a Vicryl or monocryl, for this knot. However, I'm going to use a nylon since it's black and will show up more easily against the light colored skin here. To do a buried knot technique, which is used commonly in all types of incisions, but especially small ones like laparoscopic incisions, you start on the side of the incision closest to you, and you go from deep to superficial. The deep part starts just under or at the bottom of the dermis, and the superficial part comes up at the dermal-epidermal junction. So deep to superficial. On the wound edge that's away from you, you pass it from superficial at the dermal-epidermal junction to deep, coming out at the bottom of the dermis or just underneath the dermis. Then at this point, you can use an instrument tie or a hand tie to tie those strands together. And ideally, you tie in the direction of the wound, as opposed to tying across the wound, which opens the wound edges. Try and tie in the direction or parallel to the wound. And then you cut close to the knot, and in living tissue, it's buried and absorbable. That's why I use monocryl or Vicryl. The last stitch was an interrupted buried knot technique. Could also be considered an interrupted subcuticular stitch. This is a running subcuticular stitch. For demonstration purposes, I'm going to choose not to tie knots at the beginning end. To do this, I pass from the outside of the skin in at my corner of the wound. You can start this with a knot in the corner that is buried. That's not always mandatory. It depends on the tension of the skin. Then when you're in the wound, you pick a level within the dermis and you stay at that level on both sides. You can travel anywhere from a millimeter or two to several millimeters. I generally take small bites at the corners and larger bites in the middle of the wound. You go in on the other side where you came out on the prior side, and crossing the suture over the wound helps determine where that is. You like to stay at one level throughout. That will maximize skin approximation and facilitate closure without overlapping of skin edges. I like to go in either side at right angles to the tissue and get a good healthy bite of the dermis without just skiving it. The good healthy bite of dermis, that's your strength layer. Now, since this is dead tissue, it's stiff and will not approximate well. With living tissue, these edges would come together even more nicely. Once again, this is a permanent stitch, which you can use for subcuticulars as long as you remove it after several days. But it's rare that's done anymore. Pick one level, stay in that level, get good bites of dermis. That's the strength layer. Common mistakes are to come through the epidermis and expose suture while you're running it. Want to avoid that. And at the corner, generally we tie knots, although it's not mandatory, but depends on the tension of the skin. When I do tie a knot, I use what's called the Aberdeen knot at the corner, where you keep the prior loop, you don't pull all the way down, and you pull the strand with the needle through the loop without pulling the needle through the loop. I pull that through 3 times, and the 4th time I pull the strand with the needle through the loop. That locks that knot, and then I pass the needle under the knot, around it, under and around it, and I come through the skin. And that buries the knot. Cut at skin level, and it disappears.
Well, that's it for the suturing course. It's been a lot of fun doing this. I initially wanted to make part of this course not tying as well, but I think that's going to require a different setting and more time for that too. I hope some of you can use this. Some of you can get you on your way to suturing, and others take you a bit further. It's by no means a comprehensive course, but I hope it's useful to some of you. It's been a pleasure. You take care. And if anybody needs to contact me or wants to contact me, my email is chris.carr@hotmail.com. Please allow some editing license with this. It's my first time doing it, and I deployed a few days, so I didn't have much time to actually edit it. You all take care. Bye-bye.